Hello. My name is Cheryl Walsh. I am a nurse practitioner in GI, and I have been working in this space for upwards of 15 years. I work in Arkansas for GI Alliance. Today, we're going to be talking about screening for MASH and MASLD and trying to identify at-risk patients. So kind of just looking at some of these questions, which patient populations should nurse practitioners or APPs, PAs routinely screen for MASH and MASLD in the primary care setting based on current guidelines and risk factors? In the primary care setting, we know that this can actually be a little bit overwhelming. They're seeing a lot of patients on a daily basis. So I think what we would maybe say in the GI and hepatology world is taking a look at those patients who come in and they're coming in for their pre-diabetes or their type 2 diabetes appointments, and they have obesity and they have the metabolic syndrome with those cardiometabolic risk factors such as an elevated BMI or hypertension or elevated triglycerides, and just maybe giving them an awareness to say, this patient could have MASLD, Metabolic Dysfunction Associated Steatotic Liver Disease. So why don't I, when I'm going to do their labs, I can always add in a FIB4, and that is going to give me an idea of whether this patient is looking as if they have that MASLD or even potentially MASH. Trying to make it easeful in that setting where they are seeing so many patients every single day so that it's not so overwhelming and that they have to do a number of different procedures to take a look to see if that patient has MASLD. One of the other questions, what are the most practical and validated first-line screening tools? Well, I kind of already went off on that just a little bit by saying FIB4. So a FIB4 is a calculation that is easily obtainable on many of the calculation apps, which we tend to have on our telephones or on our computer. And also you can get that just by doing the lab, and the laboratory will actually give you that data, that FIB4 number. So we're looking at a number that is baseline, looking at like greater than 1.3. And so we're looking to see if that number is greater than 1.3, what kind of follow-up are we going to look for them to look at doing? But then if it's less than 1.3, maybe that's just a reassessment every 1 to 2 years, or potentially every 2 to 3 years, depending on those cardiometabolic risk factors. So say we have that elevation of greater than 1.3, then maybe we do look at that other test that I was talking about, that ELF score, which is a lab score. And if there's a potential for elastography, maybe there's a way to get a look with that to see if we can figure out, does this patient have fibrosis? What type of fibrosis do they have? F0 to F1, F2 to F3, or unfortunately, potentially F4. So how do we communicate a positive screening result to a patient? And what are the immediate steps in management or referral? So I think I like to talk, no, I don't think I like to. I know that I like to talk to my patients in person, and I like to go over the results with them. I like to give them an explanation, because what they usually come in saying is, I've been told that I have elevated liver enzymes and I've had these for many, many years. And now I'm saying, well, it looks like you have some fibrosis. What is fibrosis? We talk about that. We talk about the progression and how progression is one of the prognostic relationships suggesting that we're going to have advanced fibrosis or advanced liver disease. And then we talk about the next steps in management. So once again, going back to that FIB4 score and using that 1.3 as a gauge. So if the FIB4 is less than 1.3, we're going to look at reassessing that FIB4 every 1 to 2 years if they have prediabetes or diabetes, and if they have greater than 2 of those cardiometabolic risk factors. And remembering that those risk factors are high BMI, prediabetes or diabetes, high triglycerides, a low HDL, looking at those cardiometabolic risk factors, knowing that they likely have MASLD if they have at least one of those, and then potentially looking at creating some imaging. Let's do an ultrasound. Let's see what that looks like. Does it show us that there's echogenicity? Does it show us that the liver is brighter colored, for instance, than the rest of the organs? And then we're going to say, we're going to reassess you if it's less than 1.3. We're going to reassess you every 1 to 2 years. And if they don't have any of those cardiometabolic risk factors, we're going to assess that FIB4 every 2 to 3 years. That gives them a way to sort of go forth. And then we're going to talk about lifestyle modification. What can you do to help with this process? We're going to look at maybe the Mediterranean diet. We're going to look at their activity levels and coming to them where they are. A lot of times you'll see patients and you'll say, oh my goodness, my doctor said I just have to exercise more, but I have fibromyalgia and I have joint pain. How am I supposed to exercise? So we want to be able to come to those patients where they're at in their life, in their journey. And then also talking about different dietary changes. Would it be helpful to maybe put them in with a nutritionist or a dietitian, especially if they have that prediabetes or diabetes type 2? I think some of the challenges that we see in really trying to implement screening when you have a busy primary care workflow is that to some, it can really just look like it's one more task that they have to do. Now I have to order a ultrasound and then I have to look at it and I have to talk to the patient about it. Or now I have to learn what a FIB4 is or what an ELF is. And then I'm going to maybe look into my community to see, is there an elastography or fibroscan machine that I can get my patient into? And I think if we just try to give them that opportunity to say, this is just first line. This isn't meaning that you have to manage this for the rest of time, but you're sort of doing that precursory work to help with your patient and letting them know, not only am I going to look at your diabetes when you come in, but I'm also going to look to see how your liver is doing. So I think uplifting them, giving them the sense that this is not something truly difficult for this job, but it's just a mild addition into that workflow. And hopefully, it can even be part of their tasks within their computer system, for instance, their electronic computer system. So really kind of uplifting them, giving them the tools and saying, thank you for doing this extra little bit of work if you're ending up sending them to hepatology, because then we're advancing that care even more efficiently once they get to us. So thanks again for listening. I hope this was informative. And if you want any more information, you can go to the MASLD and MASH community network on GAP. So thanks so much.